Today we're going to talk a bit about StimuBlast and FlexiGraft, two different types of orthobiologic products are available now. We talked a bit about StimuBlast last year, but we'll get to it today straight away. This is the demineralized bone matrix, and basically it's allograft bone, inorganic mineral removed, and it only leaves that organic collagen matrix. So this is going to increase osteoinductivity. So it's going to have exposed growth factors, but of course it does have a carrier. And there's been many clinical studies that have shown efficacy of this product in different other applications. Now, in this specific situation, this is going to use reverse phase media. Now, as you might recall, this is where it becomes more viscous at body temperature, and this is very resistive to irrigation, so it can use it arthroscopically. It is permeable to blood and is absorbed and is metabolized easily. The point being is that when we put it into the joint now as an arthroscopic environment, it's not going to go away, which is very important for arthroscopic use. Now, here's the problem. As you guys have seen before doing ACLs, that you have these widened bone tunnels. And we know that these widened bone tunnels can be quite a problem. And the etiology is multifactorial. We think it's biological, from potentially fluid propagation, increased cytokine levels, sterilization methods, implant materials, graft type, donor types, but also mechanical, graft position, fixation method. So the potential consequences of these widened tunnels is significant. This could potentially delay incorporation of the soft tissue graft. It could also have problems with graft stability, and it can also cause difficulty with future revision surgery by having these widened tunnels requiring two-stage revision. So the point is there a way we can get around this? Well, obviously there's many other factors, but one of them includes actual problems of potential fluid propagation up in the tunnel as well as fixation. So here's an example when we were doing transfix. Now, I showed you this last year, and last year we only had about a 6 to a 3 month follow-up. So this is different. So with no StimuBlast, 6 months, with StimuBlast, 9 months, you can see that there's quite a difference in the bone tunnels. There's quite a big difference. Without StimuBlast, you're seeing that nice cortical margining of the tunnel itself, whereas with StimuBlast, we're not seeing the marginalization at all. Now, since that time, we've moved to using a GraftLink technique, and you're going to see more of this tomorrow. So I'm not going to go over the technique a lot. Just know that you're going to use a flip cutter, create your GraftLink, create your tunnels. Once you have your tunnels in place, however, before you can pass your graft, you're going to have to place that StimuBlast prior. So here the tunnels are being made first. We're going to place our sutures for passing. Once all those sutures in place, we'll be set to place our StimuBlast. Now remember, because this can be injected and because it can be placed arthroscopically, naturally we're going to add some platelet-rich plasma to it, but using, in fact, the biocartilage kit that you saw earlier, that introduction kit, we'll be able to do the same thing with that same type of 2 needle that Lisa showed you earlier. And we can get right up into the tunnels and fill those tunnels with the StimuBlast. And you can see it stays right there. It doesn't float away, doesn't go away, it's not resorbed by the water. So that was first the femoral tunnel. Now here's the tibial tunnel, and you can see as that fills up, and I pull away that little needle, you can see how it just sits right in there and fills up. Once that's done, we can go ahead and pass our graft up into the tunnel, first into the femoral side. We're going to set it, bring it up into the tunnel. Then we can pass, after that, the tibial side for our all-inside GraftLink ACL reconstruction. But what this will allow is that, remember, we've placed that StimuBlast in the tunnels so it could fill around the graft. And hopefully will prevent fluid propagation up in the tunnels and better aperture fixation. We also notice that there's no extrusion. But if there is, you can always check and just wipe it away or suction it away. So that makes it quite easy. Now, obviously, we've just been doing GraftLink here for the past couple months using this technique. So I don't have a lot of long-term follow-up. So that'll be something that'll be coming. But what's clear is that x-rays are not going to be adequate to follow up. So the next step after this is to start checking these tunnels with CT scans and seeing what we're really seeing and make comparisons. So that'll be the next set of studies after this. Right now, we have 19 patients in the study group, 8 controls. We're not seeing a very large difference, really. There's no statistical difference in visual analog scale. And as you saw, the x-rays are showing good outcomes. But what the real outcomes should be will be what the graft tunnels do with the CT scans down the road. So you have to stay tuned for that. Now in terms of FlexiGraft, this is different. It is another type of DBM, but it's a sponge. And in this situation, there's no carrier. Basically, this is just a partially demineralized cancellous sponge. In our situation, we're using strips. And what we're doing is we're taking these sponges that are osteoconductive, that are bioactive, they're freeze-dried, they're sterile, hydrophilic, and we're going to use them in a way to try to promote tendon reattachment. Now the literature is looking at, in terms of tendon to bone healing, that potentially the increase in the strength of the interface can be proportional to the amount of osteocene growth. And improving the osteoconductive and osteoinductive environment can really improve that tendon bone healing. So if you take that and look at what Sunder's done using DBM, they showed that it produced significantly more fibrocartilage and mineralized fibrocartilage at 12 weeks post-op, which showed a much more mature and organized tendon-bone interface. So meaning that this interface where the tendon attaches to the bone was becoming more mature, quicker. So here we've used 7 patients so far in a pasta bridge situation, 35 for control, and here's how we did it. In a standard pasta bridge fashion, we're able to actually come through with our percutaneous kit, but we're able to introduce our sponge. Grab that sponge, and then go ahead and place our anchor directly through that sponge into the bone. So that'll be the posterior one, and now here's the anterior one. Originally, we were using one sponge for the entire repair. We've now gone using one sponge per anchor. So we're able to cut the graft and use a specific 1 centimeter area for each one. And at that point then, place our plate-rich plasma. And there's the outside, as you saw earlier, with the pasta bridge. And of course, if there's extra extrusion, just take a punch and gnaw away at whatever's left over. So you can see it's very nicely set into the repair. What's also nice about this FlexiGraft is that it is ultrasound visible. So with ultrasound, you can see it very clearly. So here example is the ultrasound of that same patient a few weeks out. And there you can see the anchors in the bone and the FlexiGraft above it. And so it's something you can actually follow and see that it is there, in place, in position. And actually within about 2 months, that's going to be gone. Currently, obviously, we've only been doing this for a few months, and we're seeing already improvement in visual analog scale scores, as well as ASCS scores in our patients over baseline control. But we're also doing so suture bridge with full thickness cuff tears as well. And what we're finding is that we're able to take these anchors, place them into our medial row. So here's the first anterior one, and here's our posterior one. And after these sutures are in place, these anchors are in place, we can go ahead and take one specific graft per anchor, pass them through the suture externally, then pass our suture through the cuff, and then introduce the graft in so that that graft will be wedged between the bone and the tendon. So that will be one of them. Now we'll do the anterior one. And there the grafts are in place. And they're held in place by the sutures that are going to the anchor. And it's wedged firmly between the tendon and the bone. Once they're in place, we can go ahead and place our PRP into position, tie our sutures, and do our standard suture bridge repair. Now we have tried this with pasta bridge. The problem is the fiber tapes are ripping those grafts. Those sponges can be, although quite robust and resist being torn, introduced, the fiber tapes have been a bit much, so we've had to go to suture bridge only for that. And of course, outcomes are early. We've only been doing this for a few months, so again, we don't have a lot of good long-term outcomes yet. And at the next point, Dr. James Cook in Missouri has plans within the next few months to begin their assessment looking at a canine model of chronic cuff tendon bone repair. And so hopefully within the next year or two, we'll have the answer whether this is really going to help or not. But the basic science does look good that it'd be quite beneficial for future repair, and actually not just helping more reliable repair, as ACP as we've shown in the past, but actually hasten repair. Thank you.